Hello, and welcome to Dermatology Weekly, the official podcast of MDedge Dermatology, where we discuss issues that most affect the specialty. I'm MDedge editor Elizabeth Mishkati. And now, your host for this week's Peer-to-Peer, Dr. Vincent DeLeo.
Today, we're talking to medical student Sheena Desai and her colleague, Dr. Rebecca Hartman, about biopsy utilization trends. Thank you both for joining us today. Could you introduce yourselves for our listeners?
Sure. My name is Sheena Desai. As Dr. DeLeo mentioned, I'm a current fourth-year medical student at Tufts University School of Medicine in Boston.
And I'm Rebecca Hartman. I'm an instructor of dermatology at Brigham and Women's Hospital, and also a dermatologist at the VA Boston Medical Center.
Thank you both for joining us today. So let's get started. So in 2019, 2 CPT codes for biopsies were replaced with 6 new codes. First, can you tell us about these changes and how they affected reimbursement?
In 2019, the coding system changed. So the 2 CPT codes were replaced with 6 new CPT codes that allowed for greater specification of biopsy technique as well as for associated procedural complexity. So rather than having one biopsy code for all types of skin biopsies, they're actually generated 2 different codes for shave biopsies and punch biopsies. And under the new coding system, shave biopsies are actually reimbursed at a lower rate than punch biopsies are reimbursed.
So in your article, you discuss results from the study that you conducted to evaluate the effects of these reimbursement changes on biopsy utilization, both in academic and in private dermatology practices. Can you tell us what you guys found?
Yeah, so we found a small but statistically significant change in the utilization of punch and shave biopsies. We found that academic practices from 2018 versus 2019 in the month of May slightly increased their use of shave biopsies and decreased their use of punch biopsies, whereas around the same time frame, private practices increased their use of punch biopsies by about 1%. So there were very slight changes between the 2 years, and they differed by practice type.
So that's very interesting. Yours was a small study. What impact might these small shifts in biopsy utilization behavior have on a more national scale?
Yeah, so while we demonstrated a small shift, when you extrapolate this to a national level, you can kind of first see the cost savings achieved by Medicare from reducing the reimbursement from shave biopsies to be substantial. So the way that we tried to look at this was if you use the total number of skin biopsies performed in the Medicare population alone, in 2015, for example, that number was 4.57 million. And if you use that as a proxy for the annual number of biopsies performed by dermatologists across the US, and you compare the reimbursement from these biopsies in 2018 versus in 2019, you can actually see that Medicare would achieve cost savings of about $18 million. And small changes in the ratio of shave to punch biopsy utilization over time can significantly change this number. And so it can really have a significant impact on a larger scale.
Yeah, that does seem like quite a difference in terms of reimbursement. Now, since you pointed out the different trends for practice and provider type, what do you think accounts for these differences?
So I think a lot goes into the decision in how to do a biopsy, and it's always, the physician's judgment ultimately that matters. And I think they're incorporating a lot of different factors. So where they think the pathology lies in the skin for their dermatopathologist, their anticipated diagnosis, the potential cosmetic outcome, location of the biopsy, the functional outcome and the intent, is it to remove the entire lesion for a pigmented lesion? So I think clinicians are, hopefully judging each patient on a case-by-case basis as they should. It's hard to say why these practices changed in a different way in academic versus private practice settings. Of course, the negative view would be, financial motivation had a role in these changes, but I don't think from our data set we can draw any conclusions because it's a cross-sectional study. We don't know why practices change. It's possible that there are changes in how biopsies are recommended over time. So the scoop shave or excisional shave biopsy is being used more and more for pigmented lesions. Perhaps that was influencing the change in academic practices. I really think we don't have enough information to tell, but I think one potential negative reason would be if practices are changing due to financial implications, because then we're not necessarily making decisions based on the patient, but we're making decisions based on the bottom line. And I think the responsibility really falls on CMS to think about how their decisions can influence practice and think about a bigger picture when they're changing reimbursement rates.
Yeah. So as you point out, there are many factors that influence the trends in biopsy selection. How do you think these can be applied to future evaluation of physician decision-making with regards to things like biopsy techniques?
Yeah, I think that, as Dr. Hartman mentioned, just accounting for things like the clinical diagnosis, the body site, the clinical experience of the physician, any time constraints they might be facing, and cosmetic concerns. I think that incorporating those factors into future evaluations of sort of biopsy selection would help account for this.
Yeah, I mean, if we got more information on why people chose to do what biopsy they did, I think that would be helpful information, both to for people to learn for their own clinical practice and to better understand the results from our study.
So for our listeners, what do you think the average practicing dermatologist needs to take away from this discussion we're having today?
I think that on the one hand, change in reimbursement to allow for greater specification of technique can be a good thing, because punch biopsies do require more expensive materials like sutures and a suture removal visit. So it is logical that they are reimbursed at a higher rate than shave biopsies are. However, I do think that the average dermatologist needs to be cognizant of the fact that changing reimbursements may hypothetically influence providers' decisions on what biopsy type to perform, especially in practices operating under reimbursement models that may be more susceptible to these reimbursement changes. And so this, has implications not only for reimbursement, but it also has implications for patients too, as punch biopsies, it may have higher risks of complications than shave biopsies. Though this data doesn't exist, it's something to think about, and I'm sure that future studies will seek to evaluate that. So there's a lot of things to keep in mind with this.
So getting to hypotheticals, can you imagine for the listeners a situation or some situations and how you would code properly in those situations now that we have these 6 codes?
Yeah, so I think the key is to remember to use the correct code for the first biopsy you're doing. So if you're doing an initial shave biopsy, the code is 1102, and then each additional shave would be 1103. But if you do a shave and a punch at the same time, they're both coded as the first code. So the shave would be 1102, and the punch would be 1104. So I think just making sure, kind of like in all of our billing, that you're going through in a stepwise way, and billing accurately and appropriately is going to be critical. Certainly the billing is more complicated to think about in clinic now with so many different options.
Well, I think this has been a very interesting discussion about what can be a confusing issue when you're working in the clinic and you're coding for your biopsies, especially multiple ones. So is there anything else you want to leave with our listeners today?
I think the really interesting finding from our study is that potentially small shifts can have a big impact. I think each patient that we're seeing is critical, that we do our best when we see them in terms of how to treat them, and that we bill appropriately, which I certainly think the average and most dermatologists are trying to do.
So once again, I want to thank you both for joining us today. Have a good day.
Thank you so much. You too.
So, thanks for having us.
That's it for this week's episode of Dermatology Weekly. The peer-to-peer portion of the show is produced by MDedge editor Melissa Sears and editor Alicia Saunders. All of our podcasts are produced by an MDedge editor, Kathy Scarbeck. I'm MDedge editor Elizabeth Mishkati, and this is Dermatology Weekly.